looking at cardiac CT, sort of how we can best use the technology right now and what we see maybe coming down the pike in the future. We're very fortunate to have Dr. Gilbert Raff here to give us this talk. Dr. Raff?
Good morning. I have to say this is one of the nicest venues I've ever been at to give a talk, and I've given a lot of talks. I mean, this is really nice. I also must say that it's a little hard for me to stand in front of you as a physician and talk to you, because having gone to MIT as a college student, I really appreciate what it takes to be a physicist, and I'm a little overawed. I have focused quite a bit of my talk on the clinical factors that enable us to come up with real-life low doses. And I hope that integrated with the technology part, that's something that you'll find valuable. I do have to disclose that I have a research grant from Siemens. And also, I will be presenting state-of-the-art technology with slides provided by vendors. But I have to tell you that I am responsible for all the mistakes, particularly in terms of my understanding what they sent me. I use these things every day, and I noticed from the program that many speakers have spoken about similar things on the technology side. But I'll try to give you a physician's perspective. Now, I was the founding director of the Michigan Advanced Cardiovascular Imaging Consortium, and as I'll show you, we've been able to achieve a 70% drop in the median radiation dose from cardiac CT between 2007 and 2011. That's quite amazing. And involving over 39,000 patient scans. This dose reduction, as I mentioned, depends not only on the advancing technology, but also on improving the skills in using that technology on the part of the radiology technologist, the physicist, the physician, and the nurse. And the future of radiation dose reduction, in my opinion, depends on faster temporal resolution in cardiac, which is really important, advancing detector technology, and automated dose reporting to improve the feedback between the physician, the healthcare system, and the patient. Now, what are the appropriate indications for doing a cardiac CTA? This is very important. You don't want to radiate people who don't need the test. First of all, the emergency and inpatient diagnosis of acute chest pain, this has emerged as one of the newest, best tools. Because what we're trying to do there is decide if the patient does or does not actually have coronary disease in the most rapid fashion. And about 75% of patients coming to the emergency department with chest pain do not have any coronary disease. Outpatients with non-acute symptoms, equivocal or non-diagnostic stress tests constitute 40% of all the images coming to the ACIC. And as an alternative to stress tests, this has also been approved by the most recent Appropriate Use Committee. This test is excellent for determining the patency of bypass and stent grafts, and also for congenital heart disease, and I'll mention the particular way that we want to change our protocols depending on what the dose is. So obviously for congenital young patients, we want the lowest dose. And the newest thing is preoperative planning, particularly for the percutaneous valve implantations that we're doing now. So we're doing these complex procedures, and CT is obviously a great way to get the three-dimensional characteristics of what may be a very complex patient heart. Now, this is one of the studies that we've published back in 2009 and details the approach that we ask people to take in using their equipment. And it was done in a large number of hospitals. You can see the consortium is about 47 different sites now, encompassing almost all of the imaging centers in Michigan. And between the 2007 beginning and the 2008 ending period, in 1 year we were able to reduce dose by 53%, and I'll show you how. The dose went from 1493 milligray per centimeters to 697. And keep that 1493 in mind. That was the median dose in 2007. Over the period of 2008 through 2010, we've been able to reduce dose by another 50% or so. That's the blue. So from the orange to the green was the initial study, and the second study, which is now submitted for publication, shows the dose going all the way down to 468 milligray centimeters. And the thing about that is, I want you to keep that number in mind too. That's the median dose. Now, the key element in this, aside from teaching, which we did extensively, was providing each site with its report card. As part of this registry, the sites are required to record the dose length product on every single patient. And we then collect the doses and have quarterly meetings and send out to the sites what their doses were, as well as the doses for every site in a confidential manner. So they get the median dose of their site, the median dose of the whole registry, and their comparative performance. And I can tell you the people who are on the bottom are motivated. This is actually a structural behavioral modification program, which is the brainchild of Blue Cross Blue Shield in Michigan. And I think that if we did this on a national level for every kind of radiation-producing examination, you would find that the radiation dose in the United States would go down dramatically. So here's a case study. A 71-year-old woman presented to the emergency room with several hours of chest pain. She has a complex history with a history of pneumonia, cough, and peripheral venous disease, leading to concerns about whether she could have had a pulmonary emboli from the peripheral venous disease. She did have a stress test, and the nuclear stress testing was positive. The patient was recommended to have a cardiac cath, but she refused. So instead, the cardiologist ordered a triple rule-out scan, which is a full thorax CT angiogram, to simultaneously exclude coronary disease, a pulmonary embolism, or an aortic dissection. This is becoming a more useful and used tool in the emergency department. But in the past, this triple rule-out would have involved radiation doses above what the median dose was for our original starting consortium. And it also compromised image quality because it was trying to get both the right side of the circulation and the left side of the circulation imaged at the same time, so the timing wasn't perfect for either. Now, this was done with a new technology, and I think you can see that the image quality is quite good. This is the pulmonary angiogram, and this is the coronary angiogram. We'll go into a little more detail in a minute. But even so, I noticed that the patient's thorax, the abdomen was also in the field of view, which was not necessary. So, first of all, the scan field was too high and too low. So the dose could have been even lower. And as part of my work, I'm constantly monitoring this at 3 different hospitals. I don't do every scan myself, but whenever I see one, I call and say, guys, did you see that you were out of the field of view? And this, over the years, makes a difference. Somebody cares. Now, this is her coronary angiogram, and you can see that there are some calcifications here. But if you look down here, the cross-section shows that there really is no impairment of the lumen. So we felt that there was very mild non-obstructive coronary disease. No cath was indicated, so she would have had a negative. Her stress test was a false positive. And this isn't uncommon. Now, here's the pulmonary angiogram, and the pulmonary angiogram is just fine. Now, the other thing about it is it's very high quality. And this is the lung field, and you can see there's an abnormality in the lung field here, which was probably related to her chest pain. So she had focal emphysema and bilateral pulmonary nodules. So this is an example of how CT technology can really expedite quick care of patients. And for society at large, this is a very important matter. Now, what were her doses? This is her protocol, and she had a topogram with a dose of 3. She had test bolus with 12. Her PE scan total was 135, and her cardiac scan was a total of 239. Now, you remember that we started out with cardiac scans being 1,470. So what did we do? How did we achieve this? Well, these on every patient in the registry, as I said, we're almost at 40,000. These are required elements that we report, and these actually go on our patient chart. And I think this is a very important thing to do. So this is the description of the scanner type, the acquisition type, the scan length, the KVP and MAS, the type of gating. And all of these things that I'll go through with you in a minute are important. We record the heart rate. We report whether they got a beta blocker, how much, nitroglycerin, all these things. Now, what were the specific dose reduction tools that we used to get this? Well, first of all, we used 100 kV. In the beginning, nobody was using that, believe it or not. Everybody got 120. We used what's called care dose, which is an active MA adjustment from the topogram, which is Siemens' name, and there are equivalents for every manufacturer. This was a Siemens dual source high pitch spiral PE protocol, and I'll mention the others, other similar protocols. And this was done cranial-caudal followed by caudal-cranial sequential CTA, or prospective gated CTA. So what we're doing is with one dye injection, we're going down this way with a very fast protocol and then up this way with a slightly slower protocol, and getting both the right side of the heart and the left side of the heart timed perfectly. So that's why we get higher quality. And then we'll talk about iterative reconstruction in this context and review each of these in detail. So these were the things that put together. Now, the median dose today for a cardiac scan in the registry is 468 milligray centimeters. And now this one was, about 350 for a full thorax, PE, and cardiac. So we're really achieving lower doses. And how are we doing that? Well, back in 2011, I was part of this radiation guideline committee, and we wrote up a series of instructions to the clinician on how to achieve low doses, and I'll go through these with you. So the first thing, and this is getting away from physics, but this is exactly why I wanted to tell you this, is that we talk to the physician and we require them to fill out the form to order the test in a specific way that allows us to know what is actually the question they're answering. In other words, if you just write cardiac CT, that isn't sufficient because I'll show you why it makes a difference. We also want them to counsel the patient so they don't breathe during the exam. They can call us if they want us to give them advice about the protocol. And again, all of these are vital because, for example, if you're doing pulmonary veins, it's very different than doing cardiac CT for coronaries, and one is much higher radiation dose than the other. So the protocol variations by clinical question. If it's a congenital heart disease, Because the coronaries are rarely the disease, we can use very aggressive low-dose protocols and even wider slice thickness. The same thing is true for preoperative pulmonary vein ablations, which are done to eliminate atrial fibrillation. You may have heard about this. The triple rule-out exams increase dose. While the advances minimize the problem, we still don't want it ordered for people who have absolutely no likelihood of having a pulmonary embolus because, that's a much wider field of view. And the transcutaneous valve planning is usually done in very old patients, and often we can do very aggressive sorts of imaging where we can get the valve in all three dimensions through the entire cardiac cycle, which allows the physicians to choose the right size valve, but it is a high radiation dose. But still, if you're doing it in an 85-year-old patient, that's probably okay. Now, in instructing the patient, we do things that make it possible for us to get lower dose scans. If they drink a lot of caffeine, it's hard for us to reduce their heart rate. If they're dehydrated, they may have trouble with the doses of beta blockers. We do want them to take their usual medications. We want to know what they take. We have to know their allergies. They also have to understand they'll be receiving radiation, contrast, hold their breath. And these all prevent time wasted because the patient didn't understand you. And one of the things that I notice a lot is that if a technologist is not open to talking to the patients frequently will breathe during the exam, and that completely wastes it because we have to do it over. Now, the nurses really, or technologists who are substituting for nurses, really have to be careful in cardiac to know the baseline heart rate, BMI, and things that make our decisions. They're really our eyes and ears. Now, there are rare sites that have physicians doing all of this, but mostly in Europe, because physicians in America cost a lot, and so we try to restrict them to the reading room. Now, here's an innovation that may not be done at your place, which is if the heart rate is low, baseline, we want them to use a hand grip to make the heart rate go up, because when they get on the table, if they don't have any beta blockers, even if their heart rate's low, it may zoom up. And we proceed to the exam only if the target heart rate is met with a hand grip. And we usually give 100 milligrams of beta blocker, which is a high dose, but if you don't start there, our experience is it takes hours to prep. And so in the beginning, sites who go 25, then 25, and 25, it becomes a very tedious thing, and they end up either making the patients waste a lot of time, tying up the lab, or they decide this is just not going to work. And the other thing is, if the heart rate's not met, the protocols can be adjusted, and most of the modern scanners can do very satisfactory scans with high heart rates, but it's at the price of high radiation. So the physician needs to be involved in a difficult case. So we say MDs must be available. Now, because the doses increase with the square of the tube potential, this is the most potent patient-specific variable that you can change. So we've become and our registry research showed that this was the most important variable. Although in the second paper, we found that using high-pitch scanners is the most, or wide detector width scanners. So those are I'll be talking about those. The body mass index determines the KVP. U.S. patients tend to be much more obese, and that's kind of a problem for us, where European doses tend to be lower. Morbidly obese patients, which we get a lot, they have no alternatives to CT. Nobody wants to do anything else. The stress tests don't work. The patients can't exercise. The radionuclide tests are just impossible to read. And so we often have to image them with very high doses, including KVPs of 140. Now, as I mentioned, there's no simple table that I can use to adjust the tube current, so all the manufacturers are very sophisticated active tube current manipulations based on the topogram. So here's the basic strategy. We also already talked about having the correct anatomical scan range. Now, beyond the time necessary to reconstruct an image, you should radiate as short a segment of the cardiac cycle as. In other words, we're only turning the scanner on to image the coronaries at the time that they're moving the least. Now, the exceptions to that are when the heart rate's very irregular and we have to scan a wider window, and we'll talk about that. So this is the most robust and the original scan protocol, which is called it's a straight helical CT with retrospective gating. Now, what do I mean by the retrospective gating part? The original scanners had no windows. These are windows in which the current is turned down from here to there. So this is the systolic portion. This is when the heart's contracting. This is the diastolic portion. So it's this window here where we want to accumulate information. The very highest doses are obtained when you don't turn the scanner window down at all, so you just radiate continuously. Now, the thing about this is that you're all familiar with the fact that you have a lot of oversampling in a high-resolution spiral scan. And in other parts of the body, you're not gating it, so you're just dependent on the pitch. And the usual cardiac pitch in a retrospective spiral scan is about 0.3. So we're really oversampling a lot. But the reason that this is useful is that I can move the reconstruction point at any time between the window. And the reason for that is if the heart rate's extremely irregular, then I can actually reconstruct beat to beat at different places. So this is our fallback for very irregular or high heart rates. Now, in the original use of this retrospective technology, you could narrow the window dramatically in patients who didn't need that reconstruction variability, and we can still do this. But for patients who have that regular heart rate now, we primarily have moved on to other protocols. The most frequently used protocol is the prospectively triggered scan. Now, the nice thing about this is not only that the scan is only on for a very short period of time, but it's also there's no oversampling. In other words, this is a step-and-shoot procedure. There's not a helix. The scanner is not on continuously. It is on, the patient moves, then it stops, patient moves, it's on. The thing is that usually you're using something called an adaptive mode, which allows the scanner to sense the previous 5 beats and anticipate what the heart rate was. And if the beat comes in at a different interval, it will skip that beat. So it can adapt and sense what. Now, if the patient's got a highly irregular heartbeat, the problem with that is that it may wait so long the patient can't hold their breath. The other thing is that the number of steps that it requires in terms of heartbeats is dependent on the number of slices in the scanner. So now that we're up to 320 slices, this is one method to get very low dose, because if you have a 320 slice scanner and the heart rate is in the right range, you can do this in one heartbeat. So you've got a very low radiation dose. So this ends up being one of the very low dose methods in 320 scanners. Now, so the recommendation is that for most patients, if you can get a heart rate between 60 and 65 or less, in modern scanners we can use prospective gating. Now, the 64-slice scanners, the original title for my talk was What Can We Expect from 64-Slice Scanners? Most of the scanners today that are being produced are more than 64-slice, so we have a lot more patients that we can use the prospective adaptive sequence on. Now, when I was starting to use dual-source 64-slice scanners, I couldn't actually use prospective scanning in most of the patients. I have a more modern scanner, and I can use in almost all the patients, and this is where the temporal resolution issue comes in, and I'll mention it more later. So this is the next innovation. So for scanners that don't have a 320 diameter. This is an alternative one heartbeat scanner. And this is another way that you can have the tube on for a very short interval of time. And what this represents is a Siemens scanner that is able to use helical scanning with two separate tube detector arrays at 90 degrees to each other. And during the interval of one heartbeat, it's getting all of these separate all these separate slices by having a very high pitch. So the pitch is 10 times as fast. It's 3 instead of 0.3. So even though we're doing a helical scan, the patient is moving through the scanner 10 times as fast. And you'll notice there'd be a big gap in this data from here to here. That's one helical slice, but it's filled in by the other two. And of course, all of this requires interpolation with very sophisticated programming in order to avoid motion artifacts. And they seem to have accomplished it. But, as I'll mention further, you really need a heart rate that's stable and less than 60. So even though I have a dual source scanner, we don't use this very often for hearts, but we do use it for aorta and pulmonary and abdomen and pelvis and so forth. So this is a difficult technique at the present time to use in cardiac because of the need to extremely low heart rates, and this is one of the advances I'm looking for. So here's the 320 scanner, and here's the point. You can cover the entire heart in one rotation. So unless you need 2 heartbeats because the heart rate is too fast, you can accomplish, a very low dose scan equivalent to the flash scanner with the current generation 320 slice scanners. Now, what are the doses that we're seeing? These actually represent the doses that are just from the cardiac portion of the scan. In the registry, we require everybody to put the topogram in and the monitoring scan, so our numbers are always a little higher. But the bottom line here is with the high-pitched spiral scan, you can actually get doses of 1.4. That works out to about 2 millisieverts to 2.5 if you take the whole dose. Now, this we mentioned before is the adjustment of tube voltage and tube current. And I'm sure all of you don't need to know the relationship between dose and noise, and that is that it's 1 over the square root of dose to get the noise. And so consequently, when you have a 20% reduction of the current, you get a 12% increase in noise. And this is always the problem, is the increase in noise. But the recommendations that we've already gone through are that we should do patient-based adjustments in both current and voltage. Now, the breakpoints that are currently used are around a BMI of 30 or a weight of about 85 kilograms. So all of the technologists should be thinking about this if they're doing cardiac. I'll mention, by the way, that one of the most important features of getting low dose is having a consistent team doing the cardiac scanning. If you just have rotating radiology technologists attempting to do cardiac, it's not going to work. There's too many things to think about at this point. I do anticipate that maybe 5 years from now it'll be so push-button that it can be done easily by a whole team. I mean a whole department. But right now, I think that the departments that are succeeding have all gone to sort of a dedicated group. Depending on how big, that may be 4 or 5 or even more technologists or just one. It just depends on your institution. Now, if you're able to do both the most modern protocol and reduce the KVP, you're going to be talking about sub-millisievert scans. And this kind of sub-millisievert scan is what the big buzzword is today in cardiac. Everybody wants to achieve that. And I think if we did that, we'd be talking about a major change in the cost-benefit ratio in terms of risk to reward. But we can't achieve that in most patients. And noise is one of the problems. So everybody has heard by now a lot about iterative reconstruction. There are all sorts of names. The acronyms are like IRIS, ACER, ADIR, and IDOS. And I will talk a little bit about the mechanism of that, although I, again, feel like I'm not the expert, you are. But anyway, there are published series of patients now coming out with sub-millisievert scans that have high accuracy. I will caution you that you shouldn't believe that this is actually happening in practice. These are all, very carefully selected patients at university hospitals. So here's a patient with 0.6 millisieverts with a very nice result. But he had a very low body mass because she was done at 80 kilovolts. Now, I think with the new iterative reconstructions, we can start to reduce KVP from 100 to 80. And furthermore, I haven't mentioned this, but, again, this is a nice series of slides from Siemens that goes through the entire image and sequence, and so I'm going to use it, even though I don't know all of the techniques that they mention. But first of all, shaping the beam, where you obviously want to scan the center of the patient where the heart is, as opposed to the periphery where you're just wasting the energy. So you all have probably got this in mind already. Then you can have filters that are also intelligent in the sense that they're being driven by active filtration, and the filtration is being sensing the object that it's trying to. So it's like ACER, but on another level. And the same thing is true at the collimator level. You have these active processes going on at every level, which I find extremely exciting. So we'll be talking about a couple of detectors. I don't know personally as much about the nano panel detector, so I want you to, go to Philips and find out. But it is striking that every single, I'll just tell this as a joke on myself, but about 4 years ago or so, maybe 5, I went to a Siemens user, their high-level user conference in Germany, and the head of Siemens physics told us that there was nothing he could figure out that was on the horizon for detectors. That was 4 years ago. Now, of course, I don't think he was telling me the truth. He was telling me I can't tell you anything about it, but he was explaining that we're already detecting every single photon. So how much better could you get? Well, all I know is since then there's been a tremendous excitement about new detectors, and I'm sure you've heard about them. I also can't tell you much about their collimator advances, but I think you all know about the geometry of the wide detector arrays, that they have to be focused in a sophisticated way. So, the development of wide detectors has been dramatic, and actually there's been more than one way to approach that, and I'll mention that. Now, this is talking about the adaptive iterative reconstruction, and this occurs at 2 levels. This is at the first level, and then these are second and third generation adaptive reconstruction, and I'll talk to you a little bit about that. I hope I don't say anything that offends you too much. Now, going into a specific technology that I've heard about, and again, I can't explain it, this is where you're getting into some quantum physics that, how can you do better when you're already detecting every photon? I don't know. But you know that what GE did was incorporate garnet, and they call it their Gemstone Scintillator. And I think one of the things that I can say about it is that it has faster recovery, so that it can detect the next photon more quickly with less downtime. And that's very important. And one of the reasons it's very important is one of the other innovations that I believe has come out of the GE platform. Now, this is another innovation that I do understand, and this is from Siemens. This is their new Stellar detector. And what they've done is basically eliminated the gaps between different components on the chip, and thereby eliminated areas that could increase the electronic noise. So they've consolidated more into one ASIC. So there are less gaps between the areas, and then there are very low connection distances, which have significantly reduced the electronic noise. And this leads to, among other things, a greater dynamic range, which is a greater contrast value at the same tube output. So these are the sorts of things that are allowing us to reduce the tube output. Now here's an example of schematics of the first and second generation iterative reconstruction. So you all know that the baseline that we're doing is a filtered back projection, and the filtered back projection is analyzed and reconstructed, then sent on to the iterative reconstruction, where you have an anatomic model-based optimization that goes through this process and finally is blended between filtered back projection and the iterative reconstruction. Now, the reason that we say blended, and you probably already know this, is that if you're too aggressive with this, then the result is that you're going to obscure some real disease or emphasize the normality because it's sort of cartoonish. And I think institutions tend to fall to a certain iterative blending that makes it readable to them and still allows them to reduce tube current and tube potential by a certain percentage. Now here's the next generation, and again, this is, I'm sure it's being done by all. Philips had it on their diagram, but I didn't get the details. And what the basic difference of the current generation is that iterations and optimization are being done on the raw data level. That is before the filtered back projection, and that's my understanding of the difference. So you have the back engine, which is optimizing after the filtered back projection, and then you have optimization on the front end as well. So what we've been talking about so far are iterations of improvement at the filtration level, collimation level, detection level, and then reconstruction level. And that's where we get modern, sub-millisievert scanning at the cutting edge. Now, your imaging sites that you are advising or where you are practicing are probably just adopting these. And one of the things that you'll find is it is very hard to use everything. It's really an art to get this to work, to put the patient and the staff and the machine with this complex variables. And like I said, I can easily imagine, and I will conclude with that, a future in which we will actually be able to get sub-millisievert scans on everyone. So this is an example of one of the types of noise that can be eliminated. And one of the things that I am excited about is, this isn't part of the discussion today because it isn't really strictly about, this isn't strictly concerning radiation reduction. But if you notice here, there's a beam hardening artifact there. And with new technology, and we're talking about the perfusion aspect of CT. In other words, what I'm not going to be talking today because of the lack of time, even though I've been given more time than anyone else, is that we're actually doing things like functional imaging with the blood flow from the contrast. And what you need for that is great uniformity. So if you have a beam hardening artifact from the aorta, it's very difficult to really read that, especially if you're trying to do it quantitatively with a software signal versus time display. And what you can do now, though, is with some of these more modern things that I'm going to talk about in a second, is remove that problem. So let's go on and talk about that a little bit. Now, this is, again, a GE slide, and it talks about focal spot deflection, going back and forth during the scanning process. And I'm going to speak about that in two different ways. Siemens has a similar model where what they call it is a flying Z spot, and they use it to sample 2 detectors within one rotation. And the result of that is, even though they have 128 slice scanners, it's actually creating effectively 250 slices per rotation. So that's an example of how software, hardware combinations are coming up with solutions, and there are many solutions. But the other thing that's very exciting about this is that, Siemens does do dual source, dual energy scanning for other parts of the body than the cardiac, because it puts out the 2 energies from each tube separately. So it can actually get a scan and deduce what the 120 and the 80 kV energy sequence is producing in terms of absorption. Everybody knows about dual energy. This is a methodology that allows you to do it in the coronaries, which is I've never seen this before. So what it's doing is it's turning the KVP switching on the same detector, so that it's actually generating the 120 and the 80 intermittently on the same detector. And the reason that the dual energy detectors can't do cardiac is because they're taking the picture at a different point in time. So if you're trying to detect the difference between iodine and calcium by using the KVP signal, if you're taking one at one time and one at the other time, the heart moves constantly. So they won't overlap and they won't co-register. And what this is doing is using the beam switching and the very fast generator switching to change from 120 to 80 within the same slice. And it's just really exciting. So this is the other part of that. It's not only the tube generation, but it's also the generation of the power output that requires switching so quickly, and this is something I've never seen before. So what can it potentially do? And I want to caution you, this is so new that they don't have any accuracy data to be sure that, doing this isn't going to lead to inaccuracies. But what they've basically done is they start with a calcification like that, and they subtract it out. So these gaps are where the calcium was. The hypothetical benefit of that is that you can actually see where the dye is. In other words, you're not looking at calcium and trying to figure out how big it was. You're actually taking the element of calcium out of the picture. Again, this sounds very exciting to me as a cardiologist and who sometimes has really difficult times reading these, but I don't want to say that this works until we see some evidence. The other thing that isn't on this slide is the exciting thing that you could take out that beam hardening artifact because you know that there's the same amount of iodine in there. In other words, it's a spectral detection of iodine content, and I've seen this done. It will be very exciting if that works. So, just sort of wrapping up, why don't we achieve 1 millisievert scans? Well, first of all, I've shown you scanners that can do 1 millisievert scans. So how come we're not getting it? The answer is, first of all, the most important reason is the majority of sites in the country do not have these scanners. They're very expensive, and you have other scanners like the 64 slice and the 128 slice that produce extremely good pictures of the heart and produce extremely good pictures of all of the organs, but why get another scanner? Well, the only reason to go this far is to get some of these bells and whistles that bring the scanner volume, vastly down, but it's only cardiac. So now, I will say that when we got the flash scanner, the Siemens version of one of these technologies, we discovered that we could do aorta, pulmonary, runoffs, and we're just publishing a paper on the reduction of dose, which was really significant. It was about 25 or 50% in the other scan. So if you're looking at this from a hospital system point of view, then you can say our across-the-board median dose is dropping by 50%. Now, here's one of the funny stories. I have time. So this is a true story. I love the chief of radiology. He is a brilliant, wonderful guy. And I'm a cardiologist, so because I'm effectively a cardiac radiologist, because all I do is advanced imaging. I'm not out there seeing patients. I did that for 18 years, and I haven't been doing it for the last 10. But the point is that I go to all the collaborative, imaging meetings, especially when it comes to buying technology. So we got this flash scanner. It was like $2 million, and we got 3 of them because we have 3 different hospitals. And so at 6 months into this, we had a meeting with Siemens, and I was very happy. I was getting really low doses. And Dr. Meswa, looked at the Siemens manager, and he said, look, I spent $6 million. How come we're not getting low-dose scans? And one of the radiologists who's very smart and is a good friend of mine, who also does cardiovascular with me, said, Dwayne, it's because we're not using the flash mode. And the reason that our hospital system wasn't using the flash mode was that the various subspecialty areas felt uncomfortable because they didn't know what they were going to get. In other words, thoracic hadn't approved it. Neuro hadn't approved it because the busy radiologist who's in charge of neuro hadn't taken the time, or abdomen hadn't taken the time to implement it, and they didn't even really know. I mean, the problem is that not every physician's like me gets into the nuts and bolts and nitty-gritty of what is happening in their department or even cares. They're interested in reading. They have other things to think about. They have a million ideas of what their job is, but often their job does not include finding out what the radiation dose is. And so they hadn't turned the machine on. They were doing the same protocols they always did, even though they had a machine that was capable of doing much lower dose. So after that meeting, we did this collaborative study, and we found that we could reduce dose across the hospital system by 50% simply by turning on the machine to what it was supposed to do. So even sites that do it in cardiac, it's very difficult to get a heart rate of should be less than 60 in a volume of typical patients, and in the lowest dose, it requires less than 60. The reason for that is the right coronary lies on top of the right atrium, which is moving even in diastole. And I found that even though you can work around that, most of my physicians, I have 10 physicians who read, are unwilling to order the flash scans, and therefore we finally had to say, we'll use it for all the other scans, but cardiac, no. Now, we have to figure out the detector issue, because if you're imaging with 120 kilovolts, it's very difficult to get down to the sub-millisievert level. And so when you have our size patients, you're going to need a very sophisticated iterative reconstruction program. But if you use iterative reconstruction too aggressively, then you start misreading. So it has to be a balance. So where do I think we're going in the future? The first key for cardiac is to increase the temporal resolution. If you could use a faster temporal resolution that we don't currently have, I'd like to be able to image people with a flash protocol or a single heartbeat protocol, regardless of vendor, on all patients regardless of heart rate. That it's got to be amazing, because then you could just bring people into the scanner and just do the scan without preparation, reduce an hour of prep time and a lot of hospital cost, and you would be able to reduce dose by 40, 50, 100%. And the result of that would be a completely different equation in terms of who would get a CT. So this would enable the use of more single heartbeat protocols. Now, an increasing detector sensitivity will obviously allow you to decrease tube output. And this is a simplistic kind of combination, because as we went through in the Philips slide, there really are innovations at every point in the imaging train. I'm not listing my desires for collimation and filtration, because frankly I don't know enough about that to understand how it's done. I know something that the beams are shaped and so forth, but I know that mathematically a lot of this is going to get better and better and better. So I will expect that there will be routine doses of less than 70 milligray centimeters in the average patient within 5 years, realizing that that would be an 80% reduction from where we are today. But I think that's very, very likely. It may even come sooner than that. Now, the last thing I want to say is that physicians and hospital systems will not change the way they do anything unless they know they're not doing it well. And they won't know unless they measure it. Believe it or not, when we started the registry in each site, as we took the site on board, the hospitals were not measuring doses. They were not recording doses. They don't know what their doses are. And you know this as a physicist and as a technologist, that frequently the machine is installed, the applications person sets it up, and then the application person goes home and they leave it set the way it was set. And so they have beautiful pictures, but they don't realize the doses are very high. So what we need is an automatic dose monitoring and reporting registry that works, I'm afraid to say it, nationally, and gives you a report and comparison to others so that you know that your technique is up to par. And thank you very much.
Excellent presentation and great slides. You mentioned that you use 100 milligram of beta blocker. Is that administered by a nurse or a technologist or a radiologist or a cardiologist? Well, it seems to be about twice as much as we do.
Yeah. It's administered by a nurse. Now, let me explain the way that this happened. We started doing this as cardiologists, so cardiologists are used to giving beta blockers. And to them, this is not a big issue. The other thing is that we were approached by the pharmacy committee, and they said, this is an awfully high dose to give people off the street. And by that time, we'd accumulated 5,000 patients, which was done in the context of cardiology. And so with that information, we were able to show that there was very low side effects, especially if you hydrate the patients. You're putting in an IV anyway. You should have the IV running. But that's not to say that it doesn't require a team that knows what it's doing. And I don't think that there's any way that you're going to achieve lowest dose if you don't give at least 100 milligrams in most patients. So we have a nurse, dedicated nurse. Now, sites that don't have that are going to have a different situation. And we actually give more than that. In other words, that's our start. If an hour later, after the dose is absorbed and the heart rate's not even close, we'll give another 100 milligrams. Depending on what the rate, the heart rate is, we might give 50. And if it isn't finally where we want it, Then when the patient's on the table, we give it intravenously. So all these things are happening, but you'll find, and I now work with thousands of sites all around the world from the Society for Cardiovascular CT, and there are all levels of control that people have over the way this imaging is done. And that's why I'm saying to you that my vision for the future is temporal resolution, where this heart rate business and the beta blockers are not an issue. But today, I don't have an easy answer for that. Your institution has to really say, do we want to do cardiac well? And if so, how do we want to shape the imaging environment to give us the optimal patient protection? We're going to come out with a paper very soon showing that the number of complications in 40,000 patients is amazingly low. Yes?
This isn't a question, it's a comment, and I appreciate very much your last slide. There actually is a national dose index registry that achieves just this, and Mike reported on this yesterday at the talk, so thank you very much.
Right. I think I know about the ACR registry. Only thing I'm not sure about is its penetration into the world. I think it has to be. Is that the one that we're talking about, the ACR?
Yes, it's the ACR dose index registry. It is the largest available dose index registry that is out there at this time. And I forgot the number of registrants, but it's been growing tremendously.
Yeah, that's great.
I just wanted to say that recognizing 6 months in that you hadn't utilized all the technology available is actually pretty good. And you should be proud of that and not embarrassed by it. We're in a big protocol review stage right now, and I'm amazed at how often we have not implemented two current modulation, the very most basic thing. No one had the chance to insert it into the protocols that were very appropriate. And I think everybody in this room probably realizes that having the technology is one thing, but implementing it successfully is a whole different ball of wax, and really can be a big can of worms, and everybody sort of forgets about that when they buy these brand new, huge, wonderful scanners that are incredibly complicated.
Thank you.